Shrikant welcome you all for this discussion on topic, how do I diagnose and treat invasive fungal infections in hematology? Our today's eminent speaker is Dr. Subhaprakash Sanyal, sir. Sir is Director, Hematology and BMT Services, Fortis Group of Hospitals, Mumbai. Sir is Hematologist and Bone Marrow Transplant Physician. Sir is Director and Hematology at BMT Services at Fortis Group of Hospitals, Mumbai. He did DM in Hematology from KM Hospital and Seth GS Medical College, Mumbai. Subsequently, Sir was awarded the fellowship at Vancouver General Hospital, BC Cancer Agency, Vancouver, Canada. He specialized and trained himself in all types of peripheral blood stem cell transplants, including autograft, related and unrelated allogenic transplant, and umbilical cord transplant in all types of leukemia, myeloma, lymphoma, and bone marrow failure syndromes like aplastic anemia, myelodysplastic syndromes, etc. Sir is a certified fellow in lymphoma from the BC Cancer Agency, Vancouver, Canada. He has authored and co-authored a large number of papers in numerous peer-reviewed international and national journals. He has participated and delivered various orations and guest lectures across the country. Dr. Sanyal sir believes in sharing his knowledge and extensive experience by lecturing medical students. So welcome, sir. Our today's eminent chief guest is Dr. Ayesha Jamshed Sunawala ma'am. Ma'am is infectious disease specialist at PD Hinduja Hospital and Medical Research Center, Mumbai. Dr. Ayesha Sunawala ma'am is also a visiting consultant at Bridge Candy Hospital and Jaslok Hospital. She is a teacher and head fellowship in ID. She is a member of the Scientific Committee for the Indian COVID-19 Guidelines Group. She is a co-author of the textbook, Casebook of HIV Medicine. She has received Women Achievers Award from Government of Maharashtra for the services rendered during the COVID pandemic. She is also a recipient of Economic Times Award for Inspiring Infectious Diseases Specialist 2022. So I welcome ma'am. Our today's eminent moderator is Dr. M.B. Agarwal sir. Sir is hematologist and hemato-oncologist at Bombay Hospital, Lilavati Hospital and Bridge Candy Hospital. So I also welcome all the eminent panel members for this discussion. Now I request Dr. Agarwal sir to set the background of today's discussion and to take it over. Over to you, sir.
Thank you, Dr. Shrikant. Good morning to one and all. As was mentioned, Dr. Subhaprakash Sanyal will be delivering the lecture today on how to diagnose and treat invasive fungal infections in the field of hematology. This webinar is brought to you by Mumbai Hematology Group, supported by CIPLA, managed by Perfect Square. I thank Dr. Vaishali Gupte, Dr. Shrikant Pawar, and the team from CIPLA for supporting our academic activity. Mr. Yash, Mr. Kalpesh, and the team from Perfect Square, Executive Committee of Mumbai Hematology Group, our chief guest, Dr. Ayesha Sunawala, our guest speaker, Dr. Subhaprakash Sanyal from Mumbai. All our discussants were themselves eminent ID specialists, or chest physician, or hematologist, or hemato-oncologist. The new participants were sparing your Sunday morning, afternoon, evening, depending upon which part of the world you belong to. We have today participants from 27 countries. Just to give you a flavor of our next weekend webinar, Saturday, 7 p.m. IST, we have Dr. Anita D'Souza. She is Associate Professor, Cancer Center from Medical College of Wisconsin in US. And she will be talking to us about AL amyloidosis, a difficult disease to treat. And the next day morning, Sunday, 11:30 a.m. IST, we have our own Dr. Chetan Dhamne from Tata Memorial Hospital, Mumbai, speaking to us on challenges and opportunities in the management of pediatric acute myeloblastic leukemia. Discussants today are a good number of excellent top people from various fields. They have been put up alphabetically over here, and I'll just give you a very brief introduction of all of them. Dr. Aditi Shah from Hematology Department, KM, Mumbai. Dr. Aditya Agrawal from he's a pulmonologist from Bombay Hospital, Bridge Candy Hospital, Mumbai. Dr. Amrit Pandrowala from Bone Marrow Transplant Team at BJ Wadia Hospital, Chiltern, Mumbai. Dr. Arpita Gupta from LTMG Hospital, Sand, Mumbai. Dr. Aruna Pujare from Department of Pathology and Microbiology, Bridge Candy Hospital, Mumbai. Dr. Gunjan Lone, hematologist, oncologist from Wockhardt Hospital, Nagpur. Dr. Kirti Sabnis from, she's consultant ID specialist, Fortis Hospitals, Mulund, Mumbai. Dr. Malikarjun Kalashetty from the Bone Marrow Transplant Center at Manipal Hospital, Bangalore. Dr. Mulidharan from Wockhardt Hospital, Mumbai, hematologist and BMT physician. Dr. Nilesh Vasekar, hematologist, bone marrow transplant physician from Medicover Hospital, Nashik. Dr. Prashant Hiwarkar from the transplant team at Bhai Jarwai Wadia Hospital, Children, Parel, Mumbai. Dr. Rajesh Chawla from Critical Care Medicine, Apollo Hospital, Delhi. He's a consultant chest physician. Dr. Ramesh Balasubramaniam, who is a hematologist at Meenakshi Mission Hospital Research Center, Madurai. Dr. Riya Balikar from Kingsway Hospital, Nagpur. She is a hematologist and hemato-oncologist. Dr. Satish Kumar, again hematologist, hemato-oncologist from Manipal Hospital, Bangalore. Dr. Tejaswini Gudibande from Majumdar Shah Medical Center, Transplant Center, Narayana Health, Bangalore. Dr. Umang Agrawal from consultant ID specialist, PD Hinduja Hospital, Mumbai. Dr. Varun Bafna, hematologist and transplant physician from Bafna Star Clinic and Hospital, Kolhapur. And Dr. Venkatesh Ekbote, hematologist transplanter, director of his center from Kamal Nayan Bajaj Hospital, Aurangabad. Dr. Suprakash Sanyal has already been introduced to you. He'll be speaking on how do I diagnose and treat invasive fungal infection. And before that, a word from me about our chief guest, Dr. Aisha Sonawala. Dr. Aisha Sonawala has been our savior by diagnosing, treating infections, which is the biggest problem with respect to morbidity and mortality in the field of hematology, hemato-oncology, and transplant medicine. She is virtually now controlling these disorders in a number of hospitals in Mumbai. Her father is my friend and was my senior at KM Hospital. He was instrumental in introducing me to many important personalities in Mumbai, because of which I took up hematology in a big way, and I'm grateful to this family. So over to Dr. Aisha to inaugurate our webinar today.
Thank you, Dr. Agarwal, for that very kind introduction. I'm humbled. Very warm welcome to everyone here today. And once again, I'm truly honored to be invited here as a chief guest. It is ironic that Dr. Agarwal should ask me to say a few words of inspiration to budding hematologists and hematopathologists, because I nearly took up hematology myself. I nearly took up a seat in Pune myself before I changed my mind and did infectious diseases, because I was so inspired by my mentor, Dr. Rajiv Soman. However, in the course of my practice as an ID physician, in the course of my practice as an ID physician, I worked very closely with hematology and hemato-oncology. And I've come to understand that it's undoubtedly one of the most challenging branches of medicine. It's dramatically evolving in terms of cutting edge diagnostics and therapeutics. There are new genetic markers, new molecules, kinase inhibitors, CAR T therapy, biologicals, you name it, every few weeks. And at the same time, when this makes it extremely exciting. And at the same time, when we are called in as ID physicians, as Dr. Agarwal pointed out, it's unfortunately to deal with the fallouts of some of these new advances. It's to deal with the collateral damage that these new treatments, which are now radical cures for once conditions that were considered death sentences. But it's the collateral damage caused by these to the immune defenses that we unfortunately, come in to deal with. And often they don't end well, often they're fatal. But I'm here to inspire you, and I want to give you a small anecdotal experience. And I hope that this story leaves you as inspired and as hopeful as it does me whenever I think about it. So, I'm going to quickly tell you about a young man in his 40s who was admitted under Dr. Farah Jijina, who is the hematologist at PD Hinduja, in the peak of the COVID, sort of between the first and second COVID wave. And he had a refractory aplastic anemia. He had been given antithymocyte globulin, and we were struggling with severe perianal sepsis and various other, infection-related issues. And like so many of our other patients in the non-COVID areas, this gentleman sort of acquired COVID and had to be shifted to the COVID area. And both the patient and his wife were extremely unhappy because he was isolated. And then there in the COVID ward, we were torn between our COVID and non-COVID patients and their management at that time. You all recall what a frenetic time that was for all of us. And when we thought that things just couldn't get any worse for this gentleman, he developed some toxicity to his antifungal prophylaxis, which was transiently stopped, and he developed rhinocerebral mucormycosis. And the reason I'm sort of talking about this case is it's very apt with the discussion that's going to follow. But when we explained the condition and its implications, its prognosis to his wife, she was completely shattered. And even as treating physicians, somewhere Dr. Jijina and I understood the limitations of what we were facing, and we knew that we were up against a huge challenge over here. But we had no choice. This was a young man with a young family, and we just dogged on. It was difficult to get the surgeons in at that time. It was difficult to perform surgery, especially ENT surgery on a COVID positive patient, as you all recall. But we went on with it, and miraculously, this man came out with his vision preserved, his sight preserved, completely unharmed, went on to completely recover from his aplastic anemia, and is absolutely well on follow-up till this day. And just a few months ago, I was deeply touched because a close family friend sent me a WhatsApp message saying that a colleague at his workplace told him that he's alive today because of two lady doctors at Hinduja Hospital who didn't give up on him. And this was the same patient. And thereafter, we have not had so many success stories, not had so many miracles. We've lost a lot of patients. We've been very unhappy about the ones we've lost. But it's anecdotes like this. This doesn't make a study, doesn't make any evidence in medicine. But it's small anecdotes like this that go a long way in motivating us and inspiring us to continue doing what we're doing, and should motivate you as hematologists to continue doing what you're doing. So to sum this up, I would say that yes, hematology today, especially hemato-oncology, is a tightrope challenge. It's extremely fulfilling and rewarding when you're on the other side, but that tightrope walking can be hazardous. It can be extremely humbling, and often one doesn't make it to the other side. But ID is co-evolving with hematology, and there are new molecules, new treatment modalities, even for the opportunistic infections that are coming up. And I think that we need to just pursue, work as a team, and continue. And I would be, as much as I dread a new hematology patient, I understand that they're also the most fulfilling and rewarding of all patients when they get better and do well. So I really encourage you all to take up this branch and do it with motivation and inspiration. Thank you.
Thank you so much, Aisha, for sparing your time this morning, speaking to us. Wonderful speech, great case that you discussed and presented to the youngsters and all of us. She has been our speaker in these webinars in past. She has been a faculty for many in-person meetings in Mumbai and outside Mumbai also in hematology and oncology forums. And she has been our discussants as well. So she has been all over. Thank you so much for always saying yes whenever invited. We have benefited a lot, and other students must have benefited a lot. Thank you so much. And now,
Thank you.
Thank you. Now we go for the lecture. Sanyal, all yours.
Yeah, thank you, sir.
Sanyal, you are muted. And your video is also off.
Yes, sir. Sir, just 1 minute I'll take.
Take your time.
Yeah. Sir, I'm audible?
Yes, you're audible. Your slide is visible. Go ahead.
So, thank you, Dr. Agarwal, our president of the Mumbai Hematology Group, and all the panelists, Dr. Aisha, our inaugurator of the meeting, and all the viewers. So today I'll be speaking about a topic, what is basically how do I diagnose and treat invasive fungal infection in hematology. I think Dr. Aisha very nicely pointed out that hematology and the ID both are very evolving branch. And there should be a good marriage between these two branches. Then only the patients get really a good benefit. And in our institute, we follow this very strongly. And all our hemato-oncology BMT patients are monitored and seen by the ID physician, Dr. Kirti Sabnis, from the day one. And at the same time, fine-tuning of the laboratory medicine, which is also very extremely important. Like Dr. Sheetal Sawant give me all the feedback and everything from the microbiology department. That actually makes a complete circle and to treat these difficult subjects of the fungal infections. So in hematology, minus infection, I think one of the easiest branch to manage, but with hematology confounded with infections, sometimes become very difficult to get the result out. That is the most important aspect of this talk. So according to WHO, the fungal disease has a significant health burden. And you can see from this data that around 50% mortality happens with the candidiasis and around 45 to 63% death happens due to the aspergillosis. From this data, you can understand that how difficult this disease burden is in the community. So I'm going to the very basic mycology. So fungus are three types: yeast, mold, and dimorphic. So Candida, Cryptococcus are the yeasts, Aspergillus, Zygomycetes, Fusarium, Penicillomyces, these are the molds, Histoplasma, Blastomycosis, Sporotrix, these are the dimorphic fungus. So in hematology, most of the time we see the interplay between the two funguses, or the Candida and Aspergillus. So one is a barrier immunity and one is a barrier plus cellular immunity. When there is a breach in the barrier immunity, you see most in the candidal infections. But when subsequently the treatment goes on, your mucosa is breached, neutropenia is prolonged, you are depleting your cellular immunity. So barrier immunity plus cellular immunity, both are going down. You develop aspergillosis. So if I little bit classify more, these fungal pathogens are molds and the yeasts. And molds are divided into two groups. One is the aseptate hyphae and the septate hyphae. These are under microscope. And aseptate hyphae is a classical example of zygomycetes like mucor, rhizopas, etc. Septate hyphae, the dermatitious mold and the hyaline mold. And hyaline molds are again classified into hyaline septate mold like Aspergillus, Fusarium, dermatophytes like Microsporum, dimorphic like Histoplasma, Blastomycosis like that. And yeast I all know, that Candida and Cryptococcus. So most important part of the fungal infections in hematology is the context, what context you are dealing with. So I always feel myself when I go to the bedside round and some questions of fungal infections are just aired. Most of the time, what clinical context and background, what we're dealing, that is the most important thing. So like personal factors, elderly patients, advanced disease, there is a previous invasive fungal infection, there or not, because we get a lot of patients from the outside for the transplantations. So I have to go through all old records, whether patient has developed any previous fungal infections, what type of antifungal agent at point of time patient received, what are the prophylactic antifungal drugs the patient receives. So these are the very important informations, always important for us. Iron overload, metabolic acidosis, malnutrition, and obviously the bone marrow transplantation setup. Comorbid conditions, uncontrolled diabetes, COPD, renal failure, liver failure, immunosuppressive agents, prolonged corticosteroid. We use in a lot of hematological conditions like autoimmune hemolytic anemia, GVHD. So a lot of hematological conditions, like many patients of the rheumatology who referred to us. So these are the group of the patients where prolonged corticosteroid is very important entity. Alentuzumab, few of our pediatric colleagues use. Anti-TNF agents like infliximab, our rheumatologist colleague use. High dose of total body radiations we use as a conditioning of our ALL transplantations. So these are the risk factors for fungal infections. Environmental factors, building works in the local environment, which is very common in our city, rooms without HEPA filter, seasonal variations, humid conditions. Bombay, you all know the very humid conditions all the time, personal habits, and the other factors. So these are the context is extremely important. I always tell my younger colleagues, try to smell the fungal infections. That is most important. And the risk factor assessment is very, very important at the bedside. So I just want to give little idea about that, how you smell the whole stuff. When the neutropenia is less than 7 days, like autologous stem cell transplantation, your risk of getting invasive fungal infections is very low. When you get to the other side, like neutropenia increases, allogenic stem cell transplantation, HLA mismatch increases, you are using ATG as a conditioning for the transplantation, match-related transplantation, haplotransplantations, that is going up. Neutropenia more than 14 days, count is not recovering. Allogenic stem cell transplantation, develop GVHD on immunosuppressive therapy. One line of immunosuppressive therapy didn't work. You had to put second line of immunosuppressive therapy. These are the very high risk of developing invasive fungal infections. So one way, low risk, medium risk, and high risk. And then again, the environmental factor, immunosuppressive therapy, comorbidity. So all these factors you have to take into account when you decide that you are developing a fungal infection or not. So there are two basic aspects. The clinical settings we already discussed. There's a radiological settings also. And there are some mycological findings also. The most difficult part is that in bacterial infections, you have a fever, you send the blood culture comes positive, your life is very easy. But in mycology, the whole problem is the clinical context, radiological context, serological context, and then mycological finding. And most difficult part is that you can't wait for the mycological findings are coming and then you start treatment. So you have to always on the toes, and you have to plan your therapy in such a way that you should not miss the therapeutic window of the patient. That should not be a situation where you got all the information, but patient is already reached heaven. That should not happen in hematology. I think that is the most important mantra in treating the mycology or fungal infections in hematology background. So clinical settings I already discussed. So radiological finding, if you're getting chest X-ray, infiltrates, nodules, chest CT, which is very rampantly available, consolidations, halo signs, air crescent signs, there is mucosal edema, significant amount of mucositis. In USG abdomen, you are getting focal lesions, target lesions. In MRI, you are getting brain infarct, ring enhancing lesions, bone erosions, sinusitis, dural involvement. So these are the things always to be contextually to be thought of with the clinical setting. And there are a lot of samples you can collect, like respiratory, tissue biopsy, blood, CSF, past cerebral body fluid, like that. Among these, the serology is very important, and the galactomannan and beta-2-glucan, what we use very commonly in our hematology practice. Galactomannan, all hematologists know, and they know how to deal with that. I'll talk about one slide with the marker called beta-D-glucan. I learned from my ID physician, Dr. Kirti, very clearly, beta-D-glucan is like a D-dimer. We all know that D-dimer is a very good negative predictive value in thrombosis. When we suspect thrombosis, our suspicion of thrombosis is not very high, and your D-dimer is low, sometimes you get away without, your D-dimer is normal, you just get away without doing the imaging for detect thrombosis. So my whole understanding about that, the beta-D-glucan is very negative predictive value for invasive fungal infections. If it is negative, you can be little rest assured. And a decrease in the beta-D-glucan level during antifungal treatment for invasive fungal disease correlated with a successful clinical response with a positive predictive value of almost 90%. So that is important. We do beta-glucan in a significant number of cases in our daily practice. So again, clinically important fungi in hematology, Candida aspergillus, and 2 to 3% cases of the mucor. Very rarely histoplasma fusarium we see in our practice. So management strategy of antifungal therapy, when and what? So most important part of a hematologist and ID physician when they work in collaboration to decide what will be the ideal prophylactic therapy. You don't allow the fungal infection happen to your patient. That is the most important challenge, and I think the most important part of your treatment protocol or treatment system. So there is no attributable signs and symptoms of fungal infection. So prophylactically, you are giving the drug. So you don't want to happen any nonsenses to your patients. I use the word like that. Empirical therapy, clinical signs and symptoms of infections, but no pathogen identified. Preemptive, laboratory tests or radiological signs are conclusive of invasive fungal infections, but no definite proof of histopathology or culture. Targeted, definite proof of histopathology or culture of pathogen, and invasiveness of the disease. So these are the 4 types of fungal strategies we use in our clinical practice. This slide is extremely important. So there are 3 main group of drugs: amphotericin B, azoles, and echinocandins. So if you see this graph or this entire chart, you can see that entire yellow covering all the funguses. So very simple. Amphotericin B is a pan-antifungal drugs. In my understanding, if we are clinically quite sure that you are dealing with the fungal infections, but we don't know what it is, or we don't really understanding what is happening with the Candida, aspergillus, mucor, or whatever, I think the better choice to be always the amphotericin B. The entire group of azoles like fluconazoles, voriconazoles, posaconazoles, and now the isavuconazole. I will spend some slides with isavuconazole in the last 3-4 slides of my talk, and the echinocandins like a caspofungin, micafungin, and nitrodofungin. So very nutshell, amphotericin, pan antifungal, fluconazole, albicans tropicalis parasitosis. Voriconazole is a drug for aspergillus, but it has a candidostatic effect. Posaconazole, I understood from my colleagues that it is basically a good prophylactic drug, not a very good therapeutic drug, works against both Candida and aspergillus, not to allow the disease to happen. And echinocandins are always a very good drug for the Candida infections. That is a nutshell of the antifungal agents in this slide. So how we approach a suspected invasive fungal infection in patient with hematological malignancy and stem cell transplant recipients with a persistent neutropenic fever, despite active prophylaxis. So when antibiotics is not working for more 4 days, comprehensive review of the symptoms and physical exams, and obtain drug level of the prophylactic agent, TDM, which is also very important aspects of managing the fungal diseases. And we do in our practice very routinely. Consider the following diagnostic workup, like CT scan, chest and sinuses, depending on the symptoms, and serum galactomannan, and I told you already, the 1,3-beta-2-glucan. Finding suggested that pulmonary IFI, possible, go ahead with the bronchoscopy. Sometimes in hemato-oncology patients, not very possible because they are bad, oxygen dependent. Their platelet count is 2,000, 3,000, but if possible, that window should be utilized in clinical practice, because we all know that bile galactomannan samples are much better than the serum galactomannan samples. Finding suggestive of the invasive fungal sinusitis, consult ENT for prompt endoscopic evaluation and biopsy. If finding suggestive IFI, proceed to surgical debridement if necessary, repeated debridement sometimes necessary. Skin nodules, dermatology opinion, and then fungal blood cultures obviously, and then biopsy of this the skin nodules, which is more easier to do. And finding not suggestive of IFI, that is also very important. So no change of antifungal prophylaxis. Assure that antifungal drug levels are at goal. Continue to monitor patient closely for signs and symptoms of infections. So when you are quite sure that if there's an infection, invasive fungal infections is going on, either in the lung, in sinuses, in the skin, start empiric therapy based on suspected etiology. And suspected etiology helps you to understand what background or clinical context you are dealing. That is the hematologist's job, to give the ID the proper perspective. What are the situation is? My ID physician always asks me, you tell me how many days your neutropenia will persist, and what is the prognosis of case, and how you want to go further if these patients come out from this particular episode of infections. So these informations to be very clearly, so that ID physicians can plan. We meet every day before our rounds with our difficult cases with ID physicians. We discuss and we sort it out accordingly, day-to-day basis, and then move on. I think the very close networking of the ID physicians is extremely important in today's world to managing invasive fungal infections. And I'm very honest to say repeatedly different forum, I always say that helps my results are significantly improved with the involvement of the ID physician from the day one. Don't call ID physician at the end of the day when the patient is dying, patient is a NORAD of 15, vasopressin of 5. Don't call that day ID physician. That day ID physician can't deliver. So you have to be very meticulous from the starting planning of the prophylaxis. Your ID physician's involvement to each of the patients will be extremely important. So start empirical therapy, and obviously consider switch to different azoles if the prophylactic drug levels were at goal. Decrease immunosuppression if possible. This is another area where ID physicians wants to decrease the immunosuppression, we hematologists don't want. So we have to reach a consensus how to decrease the immunosuppression and how much. That is extremely important. And there is a post-stem cell transplantation, GVHD. These discussions are extremely important. So at the same time, the hematologist has to understand the ID physician's perspective. ID physician also understand the hematological perspective. It can't be a monologue sort of system. Otherwise, things will be needle-setting. Perform antifungal susceptibility testing for any isolated drone for culture and adjust treatment accordingly, and verify therapeutic drug level. So invasive aspergillus, suppose it's amphotericin B, you can switch to azoles, voriconazole to POSA, POSA to voriconazole, mucormycosis, surgical debridement when necessary, plus amphotericin B, voriconazole to POSA or echinocandins, the POSA to ISA like that. Fusarium, such surgical debridement, take out the central venous catheter, amphotericin B, liposomal, plus minus switch to triazoles like that. So invasive candidiasis, high risk patient, clinical symptoms compatibility in invasive candidiasis, positive biomarker, initiate antifungal agent, recent exposure to echinocandins, more than 4 weeks, no. Yes, amphotericin B. Culture and susceptibility testing, confirm clearance from the bacteria bloodstream, endocarditis not suspected, patient clinically stable, albicans fluconazole, paracillosis fluconazole, tropically fluconazole, glabrata echinocandins, pusa echinocandins, and then oris echinocandins or amphotericin B. So most important thing, when you see invasive fungal infection is suspect clinically, all that microbiological data is not with you. Always start from the higher drug, then de-escalate, not from the other way around. That is the way the practice should be done. And what prophylactic agent is you are using, that is also extremely important to choose the proper antifungal therapeutic agent in these particular conditions. Invasive aspergillosis, you have a voriconazole as a drug of choice, and you have now isavuconazole, which is another good drug for the invasive aspergillosis. So mucormycosis, we see around 1 to 2% cases of mucormycosis, but when happens mucormycosis, you know, the mortality rates are extremely high, extremely high. So these green stuff are the things you should do always. So suspected and confirmed mucormycosis and emergencies require rapid action. I will show one case how difficulty we faced with mucormycosis in recent times. Surgical deployment with a clean margin for 3 purposes: disease control, histopathology, and microbiological diagnosis, plus immediate treatment initiation. So avoid slow escalation of the doses. If brain involvement is there, again avoid slow escalation of the doses. Liposomal amphotericin is the drug of the choice straight, 5 milligram per kg per day over day 1. If pre-existing renal compromise, bad renal issues are there, then you can always consider the isavuconazole. So it's another new drug, which is not a substitute of amphotericin B, but can be used as a salvage a lot of time in a clinical practice. response assessment, weekly imaging, stable disease or partial response, you can come down to posaconazole or isavuconazole. Progressive disease, you can add dual antifungal. Toxicity, renal toxicity particularly, you can go down to isavuconazole. Like that, you have to plan. So there is no clear-cut way to go, depending on the patient, depending on the clinical context, depending on the patient's response to the initial therapy, depending on the surgical, depending on the result of the surgical debridement, you have to choose the therapy, and mucormycosis needs a long-term therapy. So what antifungal prophylaxis algorithm we follow in our Fortis hospital? So intensive chemotherapy AML induction, 7+3 induction, or azavein induction. Our first choice is always posaconazole. If we can't use posaconazole due to various reasons, we use second choice is echinocandins, or caspofungin is our very common echinocandins we use. Intensive inductions of the ALL, pediatric ALL, we don't use any antifungal prophylaxis. But in adult ALL, where the patient's age is more than 40 years, we use either fluconazole, sometimes we use a posaconazole. If the patient is elderly gentleman, uncontrolled diabetes, we prefer posaconazole interaction as a prophylactic agent. Again, this prophylactic agent, all cases we have very intensive discussions with our ID physician colleague, Dr. Kirti, and then we plan accordingly. During reinduction phase of the ALL, adult ALL, we are not very sure. We are discussing, we are reviewing our literatures, and then we plan. At present, some patients we use, some patients we don't use. No routine antifungal prophylaxis during induction therapy for lymphoma and multiple myeloma in our practice. Autologous stem cell transplant like myeloma, lymphoma, or auto fluconazole as long as the ANC count is less than 500. As soon as the WBC count goes more than 500, mucositis settles, we stop. Echinocandins only very high risk cases like elderly, bad diabetes, previous history of candidemia, hardly we use, honestly. And in our autologous stem cell transplantation, our fungal infections rates are extremely, extremely low. Not even a percentage, not even 1 or 2%, more than 1 or 2 percentages. Allogenic transplantations, our main drug is always posaconazole as prophylaxis. Sometimes we use echinocandins when the mucositis is very severe. Now I will do 3 cases. I call in mycology, Kabhi Khushi Kabhi Gum. So few cases are good, very happy outcome. For the Aisa told, the rhinocerebral mucormycosis coming out from the ATG and aplastic anemia, and few cases are difficult for us. So she's a 42-year-old lady, AML normal cytogenetics. This is a long back case, I think 2017, if I remember correctly. NP1 mutation detected. So normal cytogenetics, NP1 mutation, AML at the standard risk AML. They do very well. So only chemotherapy, patients are cured in 80 to 90% cases. TLC at presentation is 4.7. No comorbidities. Treated with 7+3 induction chemotherapy, standard. Complicated by culture negative febrile neutropenia, recovered. Post-induction bone marrow examination, morphological remission. That point of time, we don't have the facility to do MRD. So morphological remission is a good criteria to declare that the patient has done well. Then we started our consolidation, HIDAC chemotherapy. On day 8, patient developed severe cerebral toxicity. That happens around 5 to 6% cases of the HIDAC. On day 11, started fever spike. All blood and urine cultures are negative, managed with broad spectrum antibiotic. On day 16 onwards, started dry cough, new onset low-grade fever. Day 18 onwards, count started recovering. I think it will go down, it will go away. But my luck is not so easy. We did a chest CT scan, and we found multiple bilateral alveolar nodules, along with multiple lesions over liver spleen. There are target lesions in the liver, and I shown you my initial chart that target lesions in the sonography is extremely important. So diagnostic aspiration of the liver lesion done, and you see what we got. We got a Candida tropicalis. So after 3 days of incubation, culture positive for Candida tropicalis got. Sensitivity pattern azole resistant. Echinocandins and amphotericin B sensitive. And gene expired AB cultures was negative. So it is basically hepatosplenic candidiasis. It's an invasive form of candidiasis, which is associated with a very significant mortality and morbidity. It is seen in primarily hematological malignancies who have recovered from neutropenia or recovering from neutropenia. I shown my initial pictures when there is a breakdown of the barrier immunity and cellular immunity. That is the time it happens. The disseminated form of candidiasis is rare. Successful outcome without accurate diagnosis is difficult. And the main causative factor considered is the translocation of candida from the GI tract into the bloodstream during neutropenia. Pathophysiology, uncontrolled immune response which occurs during neutrophil recovery. Incidence ranges from 3 to 29% in patients suffering from acute leukemia. Ideal treatment is with amphotericin B. So there is a twist in the story. So our patient started with amphotericin B, developed severe chills and hypokalemia with 1 dose. Second dose with slow challenge, patient had transient ventricular rhythm issues, shifted to ICU, underwent thorough eye examination, which is normal, so changed to echinocandins. She improved with antifungal IV caspofungin therapy. Cough and pain settled, but fever took 2 weeks to settle. She took total 24 days for fever defervescence, which is a known complication of hepatosplenic candidiasis. She received total 12 weeks of treatment. She also completed her remaining 1 cycle of the reinduction. So this patient, I can tell you one thing. Patient has a cerebellar toxicity and a hepatosplenic candidiasis. So we given basically 1 induction and 1 just consolidation. After that, after the completion of the treatment, we plan the patient will take for the stem cell transplantation because there is a brother which is 10/10 match, and very unfortunately, the brother died due to accidents within the same period. So after a lot of discussions, we decided not to touch her, and believe me, almost 7 years over, she comes every 6 months to my OPD with the blood reports, and she's a proud mother of an IS officer who became just qualified his UPSC exam last year. So take-home message is an immunocompromised patients, an unexplained fever that is unresponsive to antibiotic agents should raise the possibility of invasive fungal infections. Microbiological confirmation is must. Close monitoring and follow-up is as important as diagnosis, as mortality remains very high. So this is a story of the Khushi, now the story of the gum. It's really a tragic story. 36-year-old female. She had a 6 months pregnancy and diagnosed with a pH negative BALL high risk. Underwent an MTP, and she actually wanted to be mother for long. She don't have any living kid. So after the MTP, we started on standard ALL BFM 2002 protocol, poor steroid responder, achieved MRD negativity after induction cycle 2, completed that induction and high dose methotrexate phase with few hiccups, otherwise quite well. Post protocol M, MRD negative. She don't have any family match and not willing to explore any other matches and not willing for CR1 transplant. So we decided to continue with the reinduction phase. We started with the reinduction phase with the dexadoxo, vincristine, and perilateral asparaginase. Family became a little complacent, irregular follow-up was little there, but she was coming to daycare for the injections. Suddenly she brought to hospital with the abdominal pain around day 15, the day 16. Amylase lipase levels was quite high, CT suggestive of acute pancreatitis. Sugars were high. Improved with conservative therapy, hydration, and control of sugars. But on day 3 of the hospitalization, so day 18 of the treatment of the reinduction, she had watering from the left eye, periorbital swelling around the left eye. MRI done immediately. This is the image. So you can show presence of mild soft tissue swelling and deposits involving orbital apex and superior and medial rectus muscle. The primary radiological suspicion was query leukemic deposits, but I was quite in dilemma because patient was MRD negative few weeks back. So CSF was done negative. Our clinical suspicion was fungal infections, and patient was started on body corrosion straight away. Patient complained of blood vision 24 hours later, which rapidly progressed in next 4 to 6 hours to loss of vision. Ophthalmic variation, no perception of light. Increased soft tissue mass, post-orbital edema leading to optic nerve compression. Immediately, we done a day 2 only. We called the ENT surgeon. We convinced him, and the face done immediately because of suspicion of the mucor. Face guided biopsy taken. Confirmed presence of accepted hypermucormycosis. Patient underwent left eye exenteration surgery, debridement on the same day. Started on dual antifungal therapy with the liposomal amphotericin posaconazole. Therapy continued for 10 days. Initially, there is some improvement, but after 10 days, this is the picture we are getting. So increase in the mucal lesions, involvement in the meninges. Patient offered extensive debridement surgery again with prolonged course of antifungals. They had exhausted finances. They lost hope totally. Took her home for palliative care. But this rapidity of the clinical course is a great lesson for us. And she died at home within 8 days' time. Now the another case study, it's a 9-year-old boy referred from another hospital with a fever for 7 days, high-grade intermittent fever, treated symptomatically by private physicians outside. There are blue discoloration of the skin area, lips, arms and legs since last 10 days, associated loss of appetite. There are bleeding, melena, no step cough, vomiting, loose stool, blood in the stool. But history normal, on vaccinations up to date. So it was a classical case of hemophagocytic syndrome, macrophage activation, diagnosed from outside because pancytopenia, ferritin is very high, triglyceride is high, fibrinogen is low. Marrow shows extensive macrophage activity with frank evidence of phagocytosis suggestive of HLH. No mutation detected in NGS panel, and the EBV virus was positive. So it is basically EBV associated secondary HLH. Started on the steroid with the rituximab from the outside. When they came to us, and she was very neutropenic, and we got this sort of lesions, and this sort of lesions in the cheek. We did the biopsy of the lesion, and the culture was positive in the 6 days. And it is ultimately reported as fusarium. The fusarium is a ubiquitous thermally monomorphic saprophyte found in soil, plants, associated in foreign bodies, and in aquatic habitat. 3 most common variant, Solani, Oxysporum, and Verticilloides. Host immunity plays a role in the severity of the disease. Single organ involvement and most foreign body associated fusariosis are observed in patients with normal immunity. Most common localized infection in normal host are onychomycosis and keratitis. At the highest risk for disseminated fusariosis are immunocompromised patients with hematological malignancy, on cytotoxic therapy and transplant recipient. Predisposing factor is a prolonged neutropenia. A neutrophil produces NADPH and macrophage prevents germination of conidia. This is a skin lesions. Disseminated disease constitutes 70% of fusarium in immunocompromised patients. Skin is commonly affected organ, most frequently present with multiple tender erythematous nodules having black center due to central necrosis. Angio invasion by fusarium hype with thrombosis and infarct account for the ecthyma gangrenous like appearances. So diagnosis of fusarium requires culture with identification of characteristic morphological features. Involved tissue, especially skin, should be biopsied to send for culture. Blood cultures are often positive, up to 77% when compared to aspergillus. That is a little interesting finding here. Biochemical marker. So beta D glucan is usually positive for invasive fungal infection, but cannot distinguish fusarium from other fungal infections. But positive beta D glucan and a negative galactomannan in a high-risk patient with a mold infection in the background is highly suggestive of fusarium. So identify patient at risk, prolonged and profound neutropenia, high doses of steroid, skin breakdown, particularly sites of onychomycosis. Consider the diagnosis of fusarium infections in patients. Skin lesions, multiple metastatic cellulitis adjacent to onychomycosis. New pulmonary infiltrative sinusitis, especially the periorbital cellulitis. Positive blood culture for a mold. Positive beta-D glucan, but negative aspergillus galactomannan. Fever may absent in non-neutropenic patients. Implement a diagnostic workup depending on bronchoalveolar lavage and biopsy culture. Obtain blood culture. Look for adventitious sporulation in the blood and tissue specimen. Treat surgical debridement of localized infection after ruling out dissemination and or central nervous system infections. Antifungal agents, high-dose amphotericin or voriconazole if organism other than Solani or Verticilloides. If neutropenic, consider cognitive stimulating factor or granulocyte infusions that we will give. But count recovery is very important for the success of this treatment. So our case, when the skin lesions were increasing, He was initiated on liposomal amphotericin B, weight-based, and voriconazole. Voriconazole MIC is 2. Currently on conventional amphotericin B and voriconazole due to cost issues, a trough level maintained. One thing I learned from my ID colleague that fusarium sensitivity, vivo and vitro, they don't match always every time. So you have to be very careful, and the clinical response is most important key. You can see fusarium sensitivity, various types like resistant to sensitive, and the case actually we given 8 days of antifungal therapy. He was given a 1 dose of etoposide because the cytopenia was never improving and the parameters of phagocytosis is never improving, and we continued rituximab. He remained febrile, no new skin lesions, and down the line clinically getting better, WBC count improved, and he was discharged. The treatment options recommended voriconazole and lipid-based amphotericin B formulation. Posaconazole can be used as a salvage therapy, and liposomal is always better than the conventional one. The fusarium-related mortality is 50 to 70%, and a severe immunosuppression and particularly neutropenia is the most important factor with a poor outcome. Now, last 3 slides I will spend with the new drug in the antifungal block called isavuconazole. We have started using this drug of late. So there are 2 clinical indications, invasive aspergillosis and a mucormycosis. My understanding about this drug is that invasive aspergillosis, when you are not able to give voriconazole due to a lot of drug interaction or something like that, you can use this drug. And mucormycosis, particularly as a salvage regimen, where posaconazole cannot be used due to a lot of drug interaction fear, that particular area, isavuconazole can be a great help. Contraindications, not much, but drug interactions compared to posaconazole is less. Rapidly absorbed with 98% oral bioavailability, no food effect, no pH effect. Dose proportional increases in exposure from 40 milligram to 600 milligram, large volume of distribution. CYP 3A4 metabolism with inactive metabolites. Less than 1% of unchanged drug excreted by kidney, long half-life. Requires a loading dose, rapidly achieve a steady state. No clinically relevant or significant PK differences in the communities. Switching between IV and oral administration is appropriate. Routine TDM is not required in most instances, but can be done if required. Dose, IV and oral. So 200 milligram you get is an injection, and the tablet is 100 milligram. Dosing is basically can be switched between IV and oral formulation without dose adjustment. Dose is basically a loading dose, 200 milligram every 8 hourly for 48 hours, and then maintenance dose, 200 milligram once a day. Compared with the other azoles, bioavailability quite impressive. Bioavailability of the food also quite impressive. Bioavailability elevated pH is quite impressive. But we have just started learning this drug, and eventually probably it will also be a good armamentarium in our managing the fungal infections. The take-home message, smell the invasive fungal infection at the bedside. So clinical context is extremely important. And this clinical context to be shared with the ID physicians from the day one. And the what prophylactic antifungal therapy you're using, that is very, very important. Involvement of the infectious disease specialist is extremely important for the initiation of the treatment of the high-end hematological cases and BMT. Early hematologic, so every hematological institutes should have their own antifungal policy depending on their own data, and that should be periodically reviewed to formulate the correct strategy to help the patients in a better way. Thank you.
Thanks, Sanyal, for that beautiful talk, real update. Enjoyed listening to you. A lot of hard work. You prepared it very well. So we'll have questions from our discussants till they raise hand. Okay, here we are. Dr. Ramesh.
Good morning, sir. Sir, considering the aggressiveness of the spread of mucormycosis, should we consider a combination therapy like for such azole with amphotericin? Is it superior to using only a single antifungal agent? What's your take on this, sir?
So look, there are 2 things. Whatever my understanding about this entire problem of the mucormycosis, that surgical debridement should be very aggressive. I explained what are the 3 reasons, because it helps to control the disease significant way. Here the disease is so aggressive. Patient's neutropenic, patient is on deteriorating very fast, and you can't imagine the patient deteriorating in day 2 like anything in 6 to 8 hours time. When entire our system was on toss on that day. So we decided after long discussion with Dr. Kirti, we start upfront dual antitherapy for this particular case.
Sanyal, what is the standard? The question is whether you treat anybody with amphotericin alone or you give POSA to everybody in addition to ampho.
No, sir. Amphotericin alone is good debridement is fine, but yes, difficult cases, yes.
So only critical cases, dual therapy, otherwise
yeah,
you are okay with amphotericin alone.
Yeah.
The question from the audience is posaconazole a good drug for mucormycosis?
Posaconazole can be a good drug only when you control the disease adequately to surgical debridement, given a good duration of the liposomal amphotericin. Now you just want to use it as a salvage therapy or maintenance therapy. That point of time, probably the posaconazole can be a good drug.
Can I put the same question to some of the ID specialists here? Dr. Aisha, Kirti, others?
If I could take that.
Yes, Aisha.
Yes. So posaconazole, from our understanding, and again, we have no large-scale studies on this or anything, but whatever our understanding came out of default during the COVID-associated mucormycosis outbreak, when we didn't have access to amphotericin B for all our patients. And we again have sort of small case series from different areas showing that if there was adequate debridement, posaconazole did work extremely well for mucormycosis. Even on its own, there were a lot of success stories. The problem with posaconazole is when there is intracranial involvement, where we understand that the posaconazole intracranial sort of penetration may not be adequate or appropriate. In that case, amphotericin B or isavuconazole are probably more beneficial or better choices. But otherwise, data showing us that posaconazole does work, although it is not guideline driven, and the guidelines still stress on amphotericin B as the primary agent of choice.
Thank you. Anybody else wants to add anything about this posaconazole and mucormycosis? Okay, fine.
Another important thing, Kirti, yes, sir. Another important thing about posaconazole is we have to maintain the levels. So measuring out the levels is very important because it's not the therapeutic drug monitoring. We need to follow when we use it as a single agent, even for the salvage or for a continuation therapy. So that needs to keep in mind. If resource limited settings, that will be a limitation.
Which is the best day to do the levels after you start POSA?
Normally we say 5 half-life. So day 5 onwards, we can do the posaconazole levels. When that is easily available majority of the places, but we need to keep in mind, and resource limited, we have to send them outside and we have to wait until the resource.
And is there a dose difference between aspergillosis and mucor with respect to POSA?
No, there is no dose difference, sir. It's the same dose for both. 300 milligram once a day, and monitor the levels.
Ramesh, any more questions from you?
Sir, with voriconazole, generally we see patients developing hallucinations and all. With posaconazole, I have seen few patients developing hallucinations. Should we stop, completely avoid posaconazole in such patients?
Yes, Sanya.
Yeah, so I didn't understand the question. Please go ahead.
So with voriconazole, we've seen quite a number of patients developing hallucinations. I've seen a few patients with posaconazole also developing hallucinations. So should we stop it temporarily and we can restart, or and go ahead with some other antibiotic?
See, my understanding about the problem is the posaconazole. I've never seen any hallucination issues with the posaconazole. So most important thing is the voriconazole. Yes, it is known, but in my personal experience, we don't use much voriconazole. I'm very honest with you. So in our center, I'd shown our guideline. We use the posaconazole upfront, so as a prophylactic agent. So when you see this problem, so we've encountered few issues earlier. So that point of time, we just switch to echinocandins for time being. Because what happens in the night, the hallucination starts. We really don't understand is a sepsis or something happening. So it is better to be on the safer side.
Okay, thank you.
So hallucinations is a big problem with voriconazole. We face it left and right, especially before POSA came in the scene and we were using voriconazole like water. So again, from the IDs people, if somebody gets hallucination on voriconazole approach, you change the drug or you still manage it with the same.
May I take that one, sir?
Yeah, Umang, go ahead.
Hi, sir. So generally, as far as hallucinations are concerned, it's undoubtedly a problem. What we generally do is we hold on the drug. If we have the facility, so we do get a TDM of voriconazole done just to make sure that the levels are not supratherapeutic. But generally, with these kind of situations, it also really depends upon what is the site of fungal infection that we are treating. Generally, if a patient already has had hallucinations with voriconazole, we would like to avoid it. And now to go in for an alternate treatment, it will really depend if you have a CNS involvement, for instance. My preference would be isavuconazole over posaconazole because of CNS penetration issues. Also, it also matters a lot as to what are the other drugs that the patient is on. So isavuconazole relatively has lower drug interactions compared to posaconazole pertaining to the chemotherapy and whatever goes on with the patient. So that is how we generally approach these kind of cases.
Thank you, Umang. There's a related question. Somebody on voriconazole has developed severe hepatitis. You stopped it, patient is recovered. Can you re-challenge? Sanyal?
Yeah, I think the drug induced we can reach. So again, depending what type, what is a antifungal status at point of time? Is a prophylaxis or therapeutic? Whether the count recovery is happening. So there are a lot of other factors are important, but I think the drug-induced hepatitis is, mostly the transaminitis, and when you stop, it recovers and then you can restart. I don't think there's a major challenge.
So again, putting it to the ID specialist, say you are giving a therapeutic treatment with voriconazole, severe hepatitis, you stopped it, liver has recovered, can you re-challenge?
May I take this one as well?
Yeah,
Dr. Kirti or Dr. Aisha? All right, fine. All right, so generally, I think we can try re-challenging, but you have safer options available again. So it really depends upon the monetary aspect as well. As far as hepatotoxicity is concerned, all three azoles are hepatotoxic, but isavo is relatively less hepatotoxic compared to vori or posa. So if the patient is affording, then in that particular case, I would rather change over to isavuconazole. If the patient is non-affording, we can try a re-challenge of vori. But in case the hepatotoxicity recurs, in that particular case, I won't try it again.
Thank you. Aditi, go ahead with your question.
Thank you, sir. So my first question is, in a case of high-risk myelodysplastic syndrome, who is on hypomethylating agent and not a candidate for transplant either because of unfit or unwillingness. So do you give any antifungal prophylaxis who are prolonged neutropenic with hypomethylating agent, and which agent would you prefer?
Yes, we use very routinely, and posaconazole is standard or antiprophylactic choice. Yeah.
So that will be a continuous, like for how much ever duration the patient is on treatment?
Yeah, it's a very good question, but we continue.
Okay.
We
Thank
continue.
you, sir.
Only the patient responded very well after 5-6 cycles of the therapy and everything is going good. That point of time we stop.
Okay. Thank you, sir. And so my second question is, a patient with ALL on induction, due to whatever reason, has received preemptive antifungal. There is a radiological evidence, but there is no microbiological evidence. So treated with antifungal therapy, would you continue some prophylaxis through the rest of induction treatment?
No, I didn't understand your question. So is adult ALL or pediatric ALL we're talking?
not particularly adult or pediatric, any ALL during induction 1 receiving preemptive antifungal therapy. So throughout induction, the remaining 5-6 months of treatment, would you give any antifungal prophylaxis after treating preemptively?
I don't think so. I don't think so.
Okay. Thank you, sir.
So let me put these two questions to the other hematologist here. The first question was about posaconazole as the prophylactic agent for 4 to 6 cycles of HMA for treating high-risk MDS. Anybody wants to differ in any way? You do the same? Venkatesh?
Tricky, but yes, I try to convince them. If they are not convinced, at least they receive fluconazole. And I agree, until the neutropenia persists, we should persist. Once the neutropenia recovers because of therapy, we can stop.
And
That is
when you restart HMA for the second cycle, is it prophylactic or only is the problem?
Yeah, no, it is prophylactic. I think during the period of neutropenia, whatever prophylaxis we have given, we try to keep it on. Yeah.
Satish, any difference?
No, sir, I also agree, sir. I mean, I would also give just fluconazole prophylaxis until unless we have evidence. Definitely, we would continue the same agent throughout the HMA cycles. If it's just prophylaxis, I would also continue prophylaxis with fluconazole. That's what we do in practice, sir. We don't give empirical posaconazole or voriconazole for MDS high risk as of now.
All right. And the second was this business of acute lymphoblastic leukemia, induction phase, preemptive antifungal started. Will you continue it till your reinduction is over? So 6 to 8 months. Satish?
Difficult, sir. So until unless we have evidence, 100% evidence, it's difficult because a lot of interactions will happen with voriconazole, posaconazole. It's quite a challenge to continue the thing. AML definitely would have done definitely with all the consolidations I would have given Ori or posaconazole. But ALL, I agree with Sanyal that because it was preemptive.
So Aditi has a very specific question, a difficult situation is ALL only. Yeah. AML.
Yeah, here, sir, I would say if the induction is going to be something like hyper-CVAD based, I would err on side of caution and give posaconazole as prophylaxis until during that period of neutropenia, because it is definitely cost effective in hyper-CVAD setting. But I would not go to posaconazole even in a regular BFM type of induction. I think it's not really cost effective or not of like Dr. Sanyal highlighted in his talk.
Yeah, so that is another area, sir. The reinduction BFM, when you use a very high dose DEXA, what to do? So still, actually, me and Dr. Kirti is discussing. We are not even able to formulate the exact strategy yet. I'm very honest.
And during the vincristine phase, how do you give these drugs, posaconazole and all this?
So we don't give that drug on the day 8, day 15, the day of the vincristine day. We don't give the drug.
Say again.
So we don't give the azoles on that day of the vincristine day.
Only on that one day.
Only on one day.
So if vincristine is day 1, day 2 you give.
So day of the vincristine, we just omit the drug. That's all.
Okay. Again, this question to hematologist: are you comfortable giving it from day 2 to day 7? Any azole during vincristine, day 2 to day 7? I must say, Sanyal, this is a new thing I'm asking. Yeah. I get very scared of giving azole during vincristine. Okay, fine. I think let's go on. Umang, you, yes.
Thank you, sir.
Okay. Umang, you have a question for us?
Just a couple of comments, sir. Firstly, I would like to congratulate Dr. Sanyal for an excellent presentation. He's really covered the topic very well. Just about a few things about the cases that he discussed. Now, Dr. Sonawala had initially spoken about that case wherein that patient was very grateful. So I was involved with that case as well. I was her registrar that time. And the patient had presented similarly. He had acute onset swelling over his right eye along with orbital region. Now, whenever we are dealing with a hematological malignancy, whenever you have this kind of a symptom, I think Mucor needs to be ruled out before anything else. isn't it? So in that particular case, the choice of antifungal would probably be better if you are using either an amphotericin B, or high dose amphotericin, at least 5 milligrams per kg, or posaconazole to begin with, and try to get your ophthalmologists involved as soon as possible, which of course Dr. Senyal did. And undoubtedly, because the problem with voriconazole is it actually, patients who are on voriconazole, the mucor becomes a bit more aggressive in those patients. So that was number one. So whenever you have a patient with eye swelling in a hematological malignancy patient, preferable antifungals would probably be a liposomal amphotericin or isovo kind of a thing. The second thing was the third case that Dr. Sanyal presented, which was excellent, the one with the central necrosis and everything. I think he made a very important point there, that biopsy is extremely crucial at that particular point to perform. The thing is, the most common cause of those kind of lesions are generally fusarium, no doubt about that. But it can still be aspergillus, it could still be scedosporium, and that really tells us about the prognosis of the patient. If it is actually a scedosporium, then and if the patient is that sick, you would probably want to combine a voriconazole with an echinocandin at the outset, kind of a thing. So performing the biopsy at that point, understanding that this is an IFI that you're dealing with, but we still need to speciate what exactly are we dealing with to really prognosticate and to address our treatment choices. I think those were the only two comments I just wanted to make about this.
Just one question I have, Umang, for you then. An azole and candin, when you combine them together, you're combining a fungistatic with a cidal drug. So is the combination a good combination?
So it might not necessarily mean a fungicidal thing. See, as far as the mechanism of action is concerned, an echinocandin inhibits the cell wall production, while an azole actually prevents the formation of ergosterol, which forms the lipid bilayer. So they're acting at two different sites, and with a synergistic effect, the combination can still be cidal, despite adding an echinocandin with an azole for a mold infection. Now, it is not routinely recommended, but now if you actually have a patient with an IFI in a bad malignancy patient and the patient is not doing that great, then combination antifungals, especially for scedosporium upfront, would be undoubtedly useful, sir.
All right. Before we move from the subject, again, a question has come up from Mona. Sanyal, she wants to know, with all this discussion we had with Vin Christine and the induction phase of acute lymphoblastic leukemia, so which drug will you prefer? An azole or a liposomal amphotericin twice in a week, once in a week, or you will use a candin like Macafag?
Sir, we don't use that once a week in our institute. We never used actually. So our
to be very frank, Sanyal, is it required to use antifungal for AL in induction prophylactically?
Sir, adult ALL, sir, that is a question. It's always in my mind, sir. And it's always in my mind. So adult ALL, more than 40, uncontrolled diabetes, all these things. So that is a...
Then why not use candin? Play very safe.
Yeah, so then the duration of the staying in the hospital for this kind of candins. Actually, we have done sometimes like this, sir. We give the mecafungin 100 mg Monday, Wednesday, Friday. Sometimes we did also like this.
Okay. Venkatesh, your question. No, you are muted, Venkatesh.
Yes, thank you so much, sir, for bringing the ID specialists and hematologists together. And thank you, Dr. Sanyal, for the wonderful talk. My first question is about biomarkers. Do we use beta-D-glucan and galactomannan assay together or one after the other in tandem? That is, if one is negative, then the other to be used. Is there a merit in doing that, or either one or the other? That is one. And secondly, after therapy, when do we reassess the biomarker status? Yeah, that would be my first question.
So Venkatesh, we'll stop here for a moment. There are a number of questions in the chat box related to all this. So Sanyal, your views, and then I request ID guys to tell us something more about all this. So the chat box is full of it. This is an area confusing to the hematologist. How often to do, what to do, cost involved, then false positive, false negative interpretation. So yes, Sanyal, go ahead.
So we do very case-to-case basis. First of all, even you suspect fungal infection, but your aspergillosis is not very high on the card, but you suspect fungal infection, then we prefer to send beta-D-glucan. That is one thing we do. But when in the suspicion order, the aspergillosis is very high, we send the serum galactomannan on the top. When we do the BAL due to any reason, we anyway send the BAL galactomannan, that we always do. But we decide that it is like I told you, I given a nice analogy of giving the D dimer. So beta-D-glucan positive means most probably, so negative means you are not doing, probably you are not dealing any fungal infections. Positive, false positives are there that ID physicians can explain in more detail. So together we hardly send. But this clinical context we decide, and on the basis of that we decide how to send these things. And I take Dr. Kirti's help, I'm very honest, what to be sent and how to be sent and what is the order to be sent. I'm very honest.
So there are more parts of this question in the chat box. When do you repeat these tests?
We generally don't repeat, sir. Generally don't repeat. Patient's clinical response, we are quite happy with that.
And if patient remains febrile, initial workup was negative, what's your frequency of repeating these tests?
We generally, we probably do another repeat just to see the increasing titer happening with the serum galactomannan or not, like that we do. But beta-D-glucan is there is no serial increasing titer concept is not there.
Okay.
So beta-D-glucan is very basic screening test.
Okay.
Like a D dimer.
Not much repeat in your practice. Another question is use of MALDI-TOF for identification of fungi. You want to take that, Sanyal?
No, sir.
Okay. So can I put all this question to the IDs now? 3-4 of them are there. Anyone?
Yes, sir. We do help of MALDI-TOF when we are stuck with the diagnosis of fungal. Obviously, we send it to Hinduja because we don't have it in-house with us. And it does help, like this Fusarium, it was Fusarium solonine. Finally, I was identified with the help of MALDI. So, yes, we do take off help of MALDI and the results are quite quick. But as I said, it's might not be available in all centers. So it might be difficult for peripheral resource limited areas to use it, but definitely we can send a sample. Transportation can be done because it is in Hinduja. We all samples we are sending right now to Hinduja. We do take help of MALDI for identification of fungi because like Fusarium, they are resistant fungi. So depending upon the species also, dual antifungal choice of antifungal definitely differs. We definitely use it.
Kirti, you want to give your comments on beta-D-glucan, galactomannan in the beginning, during the follow-up, interpretation, false positive, all that from ID angle?
So it's beta-D-glucan and galactomannan. Both are very good tests, but as we know, they are an additional test. We can't go only like that's a EORTC classification, which clearly mentions how we use antifungals in clinical practice and how we go by beta-D-glucan and galactomannan. So these are good screening tests, but we don't based only solely on those tests for the diagnosis. Like beta-D-glucan is a pan-fungal marker, so it might be negative in mucor also. So we can't use it in all cases. So using this galactomannan obviously is case-based. And beta-D-glucan, we also sometimes need to compare the values from BAL and serum if we are in doubt if the clinical picture or the radiological picture is not completely fitting into a typical invasive mold.
Thank you. Dr. Aisha and Dr. Uma?
Yeah, may I come in here?
Yeah.
Yes. So, two things. One is about the markers and doing them serially. So, we were probably at Hinduja, we were lucky because we got beta-D-glucan. We had access to it before others and stuff. And similarly, galactomannan, of course, has been around much longer. But having said that, yes, as pointed out, beta-D-glucan, we would do it in anybody who has risk factors, which means that they are profoundly neutropenic, for both candida as well as molds, so for both yeast as well as mold, it would give us a good indication when it's negative that we can, probably lay low and, continue with our antibiotics and things like that. But would we do it serially? Yes, we would repeat it after a couple of weeks. If we find that on appropriate antibiotics, having ruled out all other things, our patient is still not improving and remains neutropenic, yes, we would do serial values to see if there is a rise in titer, especially of the beta D glucan. We would never repeat the beta D glucan once it is positive and we have made a diagnosis of an IFI, because we understand that the beta D glucan decays very slowly and there is no reliability on the period of decay. So unlike galactomannan, so let's compare it to an ESR and a CRP, right? So an ESR rises and then takes very long to come down, and it doesn't make sense to keep checking the ESR every week or every 2 weeks or whatever. On the other hand, a CRP is used as a diagnostic as well as a therapeutic marker of, disease progression, where you can do it serially and see it coming down. So galactomannan actually decays much faster, and again, we don't do it the way we do CRPs. We don't do it every 48 or 72 hours, but yes, we do repeat it to just see patient response when, when we're not so sure. So many of these patients have so many things happening. They have their primary disease, they have a bacterial infection, they have a fungal co-infection. You're not sure what's happening with the burden of each of these opportunistic infections. And so the galactomannan has sometimes helped us to understand that we might be on the right track with the anti-mold, right? Having said that, we can't use it the same way for beta D glucan at all. Again, another important thing to point out with beta D glucan is the false positives. So we have some false positives. There's a long list of them, including some rather non-specific things like sepsis, use of antibiotics, bacterial sepsis, which practically every patient may have. But what we've found in our setting is that mild rises may occur, but what we found greatly affects beta D glucan is a recent surgery, recent receipt of albumin, or blood products. And these are the ones that really throw the values off and have thrown us off and given us false positives, repeatedly. So that's an association that we've made. But otherwise, yes, we do use them. We continue to use them. And often we're stuck with them. I'll be honest that at the end of the day, the lab tests, you have to clinically correlate. Often we're stuck with them, but often they've actually sort of been the first indication of the fungal infection and helped us zone in on it. So I wouldn't completely cut them out. There was a question raised some time ago about giving anti-mold prophylaxis in ALL adult patients. And I agree with Dr. Sanyal that there is no closure on this. In fact, when I was studying ID in 2012, we had a huge discussion on this, and we had some experts from abroad who actually pointed out that if your mold infections are more than 6% in your onco unit, you need to consider anti-mold prophylaxis for adult ALL as well. And that was something that we considered then. We tried to do a study on it and look at what our rates may be or whatever, but it never ended up happening. And we don't routinely give anti-mold prophylaxis to our ALL. But having said that, yes, we do see aspergillosis off and on in our ALL patients.
Comments on the MALDI?
MALDI, when we started out, we had amphotericin B and we had voriconazole. And so we had aspergillus and mucor. That's all we understood about the molds. And there were 2 drugs to choose from. Now there are much more finer nuances into the different molds. So the different subspecies of mucor, the different subspecies of aspergillus. We also understand that there are certain subspecies of aspergillus, like a very common aspergillus flavus, for which the MICs to amphotericin B may be higher. And that's where MALDI comes in. That's where MALDI helps us. So if it gives us a particular species of aspergillosis or mucor, now you have suitable alternatives like posaconazole and isavuconazole, which you would use over amphotericin B. And that's why we try to do a MALDI sort of identification for all our cases whenever we've grown it in the lab, to just ensure that we're giving the best possible agent. So it's an evolving science, and we're understanding more and more about it.
Thank you. Umang?
So just to add on to what Dr. Soonawala said, as far as galactomannan is concerned, we also need to understand what is the what is the neutropenic status of the patient. Serum galactomannan, the sensitivity of serum galactomannan in a non-neutropenic patient is just 30%. So now if you have a patient, so especially AML, for instance, who have functional neutropenia, and this patient, you get a CT scan done even before you have started inducing before the induction therapy, you find nodular shadows with a halo sign, but the patient does not technically have a neutropenia per se that time. If your beta-D-glucan is positive, but your galactomannan is negative, I'm not going to rule out aspergillus. I'm still going to consider that that patient has aspergillus despite a negative galactomannan. So it really depends upon which situation are you using these particular things in. For instance, in ALL, you won't have a lot of functional neutropenia, but if a similar case comes in ALL, again, I would suspect aspergillus in that. And technically, there was actually a nice study done from the Mayo Clinic, which said that in AML patients in their particular setting, the incidence of invasive pulmonary aspergillosis was 10% even before the induction treatment started. And I'm sure that from an Indian perspective, this particular incidence would be much higher. And we probably would even be having invasive mucormycosis, though a formal study to that particular extent has not yet been performed. So just a few comments on this thing.
Thank you. Thank you so much. Venkatesh, any more questions from you?
Yes, sir. So that was great. Thank you for all the responses. Gave a lot of clarity. The second question is about therapeutic drug monitoring. Most of our patients who are AML patients on posaconazole start off with oral posaconazole, but eventually develop some form of mucositis or diarrhea, neutropenic colitis. In these circumstances, when patients are on prophylactic posaconazole, do you think we should use therapeutic drug monitoring? I know it sounds like an oxymoron because we're using, or do you directly switch from oral to IV when it comes to posaconazole prophylaxis?
Yes, Sanjay.
Yeah, so POSA, suppose the AML induction, you were saying that day 9, day 10, 11, when the mucositis is very bad, patient is not able to swallow anything. So that point of time, we don't do the levels, we switch straight away.
Okay.
So honestly speaking, unless or until patient is on some antifungal prophylaxis and we are suspecting fungal infections happening, at that point of time we do TDM. Otherwise, we don't do the TDM. We switch.
And my last question is, any role of granulocyte infusions in your practice that you might have explored, both from ID professionals and from hematologists, in treating invasive fungal infections? Should we do it? Should we not do it? Is it helpful? Is it harmful? Because the other side of infusions is the pro-inflammatory respiratory inflammation syndrome that we called PIRIS, which we see when patients recover from neutropenia and have fungal pneumonia to start with, and then their infiltrates go up. So do you recommend granulocyte transfusions, or are you dead against them, or you do it on case-to-case basis? How do you work?
So Venkatesh, whenever this question comes in our mind, the first thing comes in my mind that any transfusion, 15 to 20% chance of rally. But my colleagues, Dr. Hamza, is extremely aggressive about the granulocyte infusion. And believe me, he given me a wonderful result with the granulocyte infusion in last 3-4 months' time. So I'm started believing very strongly granulocyte infusion, and our apheresis unit is extremely strong. Just you have to tell in the morning, the evening, my granulocytes are ready. So my logistical problem is not there. I am also learning and tuning with Dr. Hamza's idea, and a lot of times we are actually luckier. What you are saying, it always hits me, the 15-20% chance of rally. I never faced, but any point of time I can encounter that problem. At that point of time, my views will be more balanced, I believe. But it helps.
Thank you. That's great. Thank you so much.
Sanjay, 2 questions over there. Use Buffy codes or you use single donor?
We use single donor, sir.
Use single donor. And what do you prime the donor with?
Dexamethasone.
Dexamethasone. No GCSF to the...
Yeah, Dexa and the GCSF, 1 dose of GCSF.
You give both. Yeah. What is the frequency you give this granulocyte transfusion to your patient?
So generally, we try to pull at least 48 hours.
So every 2 days.
Every 2 days.
Okay.
It
And
helps personally aplastics very well, sir. We tried a couple of aplastics, touch wood, that all gone very well.
in transplant setting or in medical treatment?
Transplant setting also we did, aplastic also we did. Leukemia also we did, sir.
But medical treatment, aplastic anemia, neutropenia is a very, very long treatment, right? So you go
Sir,
on and on with this?
Sir, we given one patient for 4 doses. It worked somehow. I don't know what worked, but it worked.
What's your indication?
So, sir, the patient was very badly septic. Around, I think I remember correctly, around day 7, WBC count is less than 100. So ATG is already over. So we just out of the blue moon, and I think the XDR Klebsiella was there. So Dr. Kirti is also okay. You do something, you increase the neutrophil count, otherwise I can't help you. So that is the desperation we did, and it worked, sir. We given 4 doses, I believe, almost 12 days interval, 2-3 days interval we given. Started coming up around day 20, and I was through. So honestly speaking, sir, this we do very case-to-case basis. We discussed a lot in our team in the morning file round and then protocol.
I have one question. When a treatment is around for 40 years and if there is no consensus, then is it a good treatment?
I fully agree with you, sir. So that is the argument that day me and Dr. Hamza was doing. And he only told this statement very clearly. That's because it is there, but probably it is not never first line because there are a lot of problem. Unfortunately, we have not faced any problem yet, sir. He told me the same thing.
There are a lot of hematologists around over here. How many of you are strictly not using it? And how many of them are using it left and right?
So strictly not using it.
Satish, 0. Okay. I'm with you. Huh? I'm one of you. Okay, then Venkatesh.
I've used it. I've used in at least 4 or 5 cases, 3 of which have not worked out, 2 of which have worked out. But again, those 2 were in post-transplant setting. Yeah, it's a tricky situation. Desperate. Only in desperate.
Tricky situation even to interpret whether what has worked.
Yeah,
true.
That is most important, sir. What has worked?
Yeah, Vasika, you suddenly opened up. Tell me.
No, sir. No, I mean, we have not used it, but we are planning to use it, sir, for post-transplant. In post-transplant settings, who are going to get neutropenic and antibiotics are not working in that situation. Yeah.
Planning to use it based on reading, literature, others' experience, or
others' experience, sir. Others' experience.
Okay. Yeah. Aditi?
Sir, in my residency in NH Bangalore, we have used it to pull out a lot of septic patients, both in EML induction and transplant setting. And it has really worked. Like I worked with Dr. Hamza, and I am also a strong believer of using it when it is an absolute dire situation to pull out the patients from sepsis. And it helps. I have seen good results.
So just one comment.
No, just 1 second to Aditi. Dire situation means what?
So like
how many days of antibiotic, antifungal, and
no
what
risk.
is happening to the vitals?
Yes, sir. So dire situation is before the patient is hemodynamically unstable, however, continues to be septic, like for example, fever or any symptoms of sepsis with a full spectrum antibiotic and antifungal cover.
For how many days? Because this is a situation for every patient.
So this is mainly we have used in AML induction. So we know that the neutropenia will recover after 2 weeks, 10 days to 2 weeks, and in post-transplant setting. So till the neutropenia recovers or the patient is symptomatically better. So it may be 2 or 3 infusions or 4 or 5 infusions.
No. Starting point. So you got a neutrophil count of 0. Your patient is febrile. You started antibiotics today. You added another antibiotic after 2 days. You added antifungal on day 5.
Yes, sir.
Now another 2 days are over. So 1 week is over. Patient is on couple of antibiotics, antifungal, and he's febrile.
Yes.
All these patients will get now neutrophil support by say day 8 or so.
So if the patient is say on all this support but clinically looks all right, except for fever.
Yes. Yeah, that's right.
We won't start, but if we feel that the patient is having a sick look or like tachycardia, but not developed hemodynamic unstable septic,
But
Such
not
patient-
unstable.
Yes,
So
sir.
you will start.
Yes, sir. And
So-
hemodynamically unstable, we will definitely give, sir.
All right. Ramesh?
Sir, during my residency, I have not used, but currently in the center where I'm working, we are using it in patients, transplant patients who are can take on inotropic support. We are using it in
Patients needing inotropic support.
Yeah.
I got it. Got you right. Okay. Are there other hematologists here? There are. Yes. Malikarjun, Tejaswini, Riya. If you want to answer. Okay, fine. That's okay. IDs, guys, want to say anything?
Can I ask a question here?
Yes,
This
yes.
is probably, I mean, this is based only on an observation. But I found that, yes, I have worked with hematologists who have given granulocyte transfusions from time to time. I found that as long as the patient remains septic, it doesn't make any difference. When it does help, it helps because the sepsis is settling. But then again, that might be an observation. So can we sort of hold these two as independent of each other, or do they work in tandem? Because from what I understand, if the sepsis is not controlled by what we're doing, either there is a source that is out of control, or for some reason the antibiotics are not able to target it, or you're not on the right antibiotic. Regardless of what granulocyte transfusion the patient receives, there's no improvement in the counts at all. Is that just my own personal observation? Am I wrong about it?
I did exactly get your question, but say somebody's count is 0, he's getting fever, he's on 2 or 3 antibiotics and 1 antifungal. Now, from the guys who are using it, I got the feeling that if the patient now becomes septic and still not unstable, they start using it. I'm not sure whether they really do it for everybody because it's not cost effective, it's not that easily available, and I don't think it is being used that liberally. But anyway, that's what they meant today. So my question to you is, from your literature or from your personal use, you do it or you don't do it? In Hematology Society, I can tell you that over 40 years, there is no consensus at all. There are centers doing it, and there are most of the centers not doing it. That's sort of the short of it. Including mycologists and all this, there is a division.
So what I was trying to point out, or what I was trying to sort of ask, and it's a genuine question, is that my observation has been that despite granulocyte transfusions, when they're given in this situation, unless you have the sepsis under control by either source control or effective antibiotics, the counts don't improve.
Okay. So are you saying that
increment in the count by giving granulocytes?
So are you saying that sepsis is the cause of low count? Continuing sepsis is what you're trying to allude to?
Yes, I'm trying to say. Yes, that is what I'm trying to say.
That is what she's trying to say. So the way I look at it, definitely not. Sepsis does not has not been shown to prolong the period of neutropenia. Number one. Number two, period of neutropenia definitely correlates with mortality and sepsis. Number two, if we can shorten the period of neutropenia by giving granulocytes to the tune of 10 to the power 8, that is what we should target. If we are not getting that target, then it is useless. If we are hitting the target with the collection and yet the neutropenia is not recovering, it is definitely useless. Now, the reasons for that may be varied. They can have anti-HLA antibodies, they can have splenomegaly, and that may be the reason that the neutropenia is not recovering because of, in spite of giving granulocyte transfusions. But secondly, in the patients where the neutropenia responds to granulocyte transfusions, it definitely improves prognosis of the patient, that immediate prognosis. I'm not talking about long-term prognosis.
This response lasts for how many hours?
Correct. So that is what. So a minimum. Yeah, in studies which have shown a response duration, at least 8 to 10 days of granulocyte infusions are usually given, which is on a daily basis. Yes. And which is prohibitively expensive and out of reach for most, even clinicians and patients included. So yes, it's very difficult to prove a point. But again, I'm trying to only answer the point where she is trying to say that sepsis induces neutropenia. I think that's a bit far-fetched.
No, anyway, in hematology, it's a different situation. You created a bone marrow suppression, or there is a pre-existing bone marrow suppression. So your counts are 0. They're going to last for 2 weeks. At the end of 1 week, you have exhausted your antibiotic, antifungal, and you know that this patient is going to succumb. So as a desperate measure, you are giving granulocytes. Their half-life is such that I mean, if you want to do it, you'll have to do it almost daily.
Yeah. And in fact, sir, if I may interrupt, beyond granulocytes, the product also contains certain adhesins which improve endothelial dysfunction and also tissue damage. And this has been studied by Dr. Revati Raj in pediatric population, where she regularly uses granulocyte transfusions. She's able to achieve the target which is difficult to achieve in adults in terms of numbers. And she's also looked at other biological biomarkers which improve the prognosis in transfusion in post granulocyte transfusion patients. So it's not only the number of granulocytes, but also the other molecules which improve the endothelial dysfunction and the tissue damage that comes with sepsis. And that's what she has shown in her papers. So that is the only lead we have so far from India.
Sir, my understanding is it will give you little more time to act. Just it will give little more, it will prolong your...
Definitely.
Yeah, you just give you time to act. When patient is fighting, patient immune system started fighting, counts are coming up, you will give little more extra support to the patient.
And why alternative?
Yeah, for example, we give GCSF, and try to, and we have shown that at least a median of 3 days we can shave off from the duration of neutropenia, irrespective of the amount of sepsis. So I think,
that is a different thing. That from, say, 20 days of neutropenia, you're bringing it to 16 days.
Correct. In the same way,
here you are talking about giving a 6 hours increment in neutrophils. And then you have to do it on daily basis or maybe twice a day. I don't feel this logical that give it alternate day and you're going to achieve something. And my personal observation now in Hinduja Hospital, Dr. Deshpande does it. Whenever he goes for donation drive, they collect a lot of blood. They are ready to give us any number of Buffy codes. The increment is in 1,000. And whenever we ask for a single donor granulocyte, the increment is 100, 200 at the most, not even more than that. So anyway, that's all. A lot of discussion we have had. We will have to move on.
So we used to give daily.
Yeah, it has to be at least daily. Sure. Satish, your question.
Thank you, sir. Thank you, Sanyal, for the presentation and lovely interaction and lovely discussion. Learned a lot that treatment is not just individualist, but center-based also. And we do have so many differences between us in practice. Unfortunately, there is no consensus. Consensus is very difficult to achieve. So, Sanyal, first thing, AML patient on, you have said that posaconazole prophylaxis you give for mostly during induction. If they develop a breakthrough fever and CT shows some infection, preemptively, what do you do after posaconazole prophylaxis, preemptively, before you have a confirmed diagnosis?
So whenever we suspect that is a breakthrough fungal infections and we don't have all the data of the culture and everything, my ID physician is always moved to the liposomal amphotericin B.
Okay, that's what I want to know, whether you add echinocandin or liposomal amphotericin.
Liposomal. She prefers liposomal, that I have seen.
Satish, echinocandin will be inferior in this setting.
Yeah.
Correct, sir. So I also do the same thing, sir. Liposomal ampho, when we don't know it's Candida aspergillus, I do that. I just wanted to find out. So second, sir,
my understanding is very clear. When you know it is fungus and you don't know what fungus, your prophylaxis is not working, go for the broad spectrum antifungal.
Completely agree.
The other thing is isobuconazole availability. Has it made an impact that everybody goes to liposomal, or you have patients on isobuconazole?
We use very few patients of the isabu when we know the diagnosis very well. It is either aspergillus or mucormycosis like that. We are learning at this drug.
These are all patients where there is no proof of fungal infection, isn't it?
Yeah, when there's no proof, sir, I don't think so Isavu is a good drug, sir.
Where
So I
there is
think intuitively better to go to liposomal ampho or ampho. I mean, in Vancouver, we used to give only conventional ampho B. A lot of times, due to financial problems, we give ampho B, and I see that young patients tolerate very well. We don't see any issues compared to liposomal.
Yes. Conventional ampho is not
Satish, that time isoconazole was not there when you were
Yes,
in.
sir, yes, it was not there. That
Okay.
was 15 years back. So
Your
the second
question.
So second question is to you, sir. You have discussed just now, you asked about ALL prophylaxis. So we don't give any prophylaxis in ALL patients, but adult ALL, I right now have a 55-year-old adult ALL, diabetic on multiple OHA and insulin and things like that. She's starting induction. Do you give any prophylaxis, sir? Or when do you give prophylaxis in ALL, sir?
If you're asking me, I don't give except this kind of patient that you just mentioned, then I use echinocandins.
Echinocandins.
I dare not give an azole with vincristine. I have serious problems.
Okay, sir. Caspofungin probably. Caspofungin is a preferred
Or echinocandin or mycofungin.
Mycofungin.
My practice is mycofungin, but Sanyal uses caspofungin. That's fine. That's okay.
Right. Thank you, sir. Thank you so much.
Tejaswini.
Good afternoon, sir. Good afternoon, sir. Thank you. So my question is actually the same thing. How much about the fungal infection is told before starting chemotherapy for acute leukemia? Because in a tertiary care center, maybe patient will be willing for the patient has come for treatment, but if patient is diagnosed in peripheries, they will be counseled by the general physician that there is a lot of infections after this treatment. These type of infections can occur. So how do we counsel before starting? And also whether the second question will be
Tejaswini, we'll take your second question later on.
Okay.
First question.
Sorry, Tejaswini, can I just brief your question?
So the physicians warn the patients that with all this treatment that Dr. Sanyal is going to give, you will probably have a lot of morbidity and mortality due to infection, especially in a little tier 2 cities and all that. So how do you handle this situation?
Yeah, so my answer is very simple here. So if you don't want to jump into the sea, anyway, you will be dying in 100% cases. So I'll talk like that.
Okay, Tejaswini, I have a little different opinion. There are a lot of patients who are very clear that they don't want to die of the treatment. So for example, in AML today, you have HMA plus venetoclax, which is not a bad induction treatment for number of, and it can lead to the incidence of transplant in exactly the same number. You can achieve molecular remission with this protocol without using 7+3. Similarly, in CLL, today you've got molecules which can totally take away your chemotherapy. You need not give it to even a single patient. Similarly, in relapsed ALL, you've got Besponsa, which can give you complete remission without using chemotherapy. So I think we are slowly entering the era where you can avoid these life-threatening infections, especially in India. The infections in India is a nightmare, virtually. So you can avoid them in number of situations. So in tier 2 city, I would say people should be very careful of using 7+3 or FCM or treating relapsed ALL with hyper CVAD, etc. I don't think you should venture at all. Why should you? Do you do that? Tejaswini, what do you do?
Sir, yes, sir. In Bangalore, sir, gives HMA with venetoclax for some patients.
Bangalore, of course, is an advanced city. Yeah, Vasekar, your question. Sorry, Tejaswini, you had one more question.
So the awareness of HLH is increased. So many ICU critical care physicians, they think about HLH and start treating with steroids. So at that point of time, do you advise antifungal prophylaxis?
Fascinating area. Okay, Sanyal.
Yes, when you give the DEXA, no, with a very high dose of DEXA, you give. We use that antifungal prophylaxis. Yes.
So fluconazole is a standard of care.
Yeah, fluconazole is fine, sir. For these cases, infection-associated HLH, fluconazole is standard one. Yeah.
Okay, Vasekar.
Yes, sir. Sanjay sir, a nice presentation. And where do you keep itraconazole over worry and fluconazole in AML prophylaxis? Because some of my patients are very poor, so I use itraconazole. Your take on that?
Nilesh, I never use itraconazole in my practice. So I think anyone can take this question. I never used.
I think we have only oral itraconazole and it's a huge problem. So I don't think we use it. I only see the dermatologists using it left and right. So they use it for cutaneous tinea infection, a lot of prescription. Again, ID guys.
I think there's some issues of the QTC also, if I'm not mistaken.
Assumption is the biggest problem for you.
Yes, sir.
They are there.
Yes.
Yeah.
Itraconazole, we're talking about itraconazole, we barely use because we hardly ever achieve levels despite, trying to change different formulations, different brands. I've rarely ever achieved levels in my patients with itraconazole. On the other hand, QTC seems to be equally a problem among the azoles, least so with isavuconazole. So the only azole which actually reduces the QTC is isavuconazole. All the rest of them can have a QTC prolongation problem.
Okay.
Right. No more raise hand sign. You want to take some questions, Sanya, from the chat box? We have covered many of them, or they are similar, but there are few lying there. How long do you give amphotericin B for hepatosplenic candidiasis? Is one question.
The total treatment duration recommended is for 3 months, sir. So,
Aisha, you want to say anything?
Actually, what is recommended is until complete clinical and radiological resolution, and that can sometimes be, even be a little longer, perhaps. It's difficult because you don't have anything to start with, so you have nothing to fall back on. But radiology is what is the only probable, anchor, because the patients are doing well in a couple of months. But once the radiological lesions have completely settled, unlike other infections where you don't wait for radiological recovery, this one is particularly mentioned.
for this patient, 3 months.
The other question we have, I think, from Myanmar. In a patient with renal impairment, creatinine 3 to 5 times above normal. And if you want to use a broad spectrum antifungal, what do you do? So today you have an answer. Yesterday we didn't have an answer. Yes, Sanjay.
I think here Isavu can be a good drug, sir.
Yeah.
Yeah, Isavu is a good drug.
Dr. Aisha?
Also, we're talking about a patient with renal dysfunction. Right?
Yes.
So the IV formulation has a cyclodextrin like voriconazole, which is why you try to avoid it. But otherwise, oral fosa, isavuconazole are all sort of acceptable options. Of course, the echinocandins.
Yeah.
Okay. Injectable ISA, any problem? Or it also has cytodextrin?
No.
It doesn't have.
Isavuconazole is fine. Isavuconazole is fine.
Okay.
They don't require anything, sir.
Other question she has is about liver impairment. Again, enzymes 3 to 5 times. Now, what are the drugs you don't give? So many azoles you don't give. But overall, what do you choose?
Echinocandins, sir. Echinocandins.
Yeah. Except probably...
Again, among the echinocandins, you'd avoid Caspo. That's right.
Caspo, yeah.
Caspo. Yeah. Okay. Let me see if there is anything unanswered.
So there is one question, sir. Would you screen all febrile neutropenic patients?
Go ahead.
Yeah. So AML induction and then all transplant patients, we do HRCT screening.
Then Aisha, you can answer one question about pediatric practice. What should be the dose of voriconazole? They require higher dose. So how high the dose is?
Yes, they've actually gone as high as 8 mg per kg 12 hourly. And they recommend that you continue that dose because children pharmacokinetics are different.
Right.
But it's very important to remember that the pediatric age group is the most vulnerable to fluctuations in levels. And so it's far more important to check drug levels in the pediatric population than any other population.
Right. Okay. One question is for you, Sanyal. Do you give antifungal prophylaxis while treating autoimmune hemolytic anemia?
Yes, sir. Autoimmune hemolytic anemia steroids I use because I had a very bad experience of getting the nocardiosis in starting my practice. And this patient is from Myanmar only. So honestly speaking, sir, I use fluconazole 200 mg.
Nocardia will be a different problem, no?
Yeah, but I know, sir, but I was so I use, sir. Autoimmune hemolytic anemia I use.
Okay. I think we have covered almost everything.
Yeah, yes.
Yeah, Sanyal, thank you so much for doing all this for us. I think those who are in the audience, huge number of students, they must have benefited a lot. And seniors, I think, also must have sharpened their knowledge. Grateful to all the ID specialists here, Aisha, and Umang, and Kirti, who have added so much to our knowledge, and all the hematologists for showing us the differences. So I hand over now to Dr. Shrikant Pawar.
Thank you, sir. So now, sir, we'll proceed for the vote of thanks. So
Yes.
on behalf of Team CIPLA and in person, I'm thankful to Dr. Ayesha Sunwala ma'am for inaugurating this session and also for the active participation in the discussion. I'm thankful to Dr. M.B. Agarwal sir for moderating this session. Sir, really, your moderation was very excellent, right? You put forward all the important questions. And also, sir, thank you for your valuable guidance during the discussion. I'm thankful to Dr. Subhaprakash Sanwal sir for the wonderful presentation. So you covered all the aspects of the diagnosis and the treatment of fungal infection in the hematology. I'm also thankful to all the discussants for sharing your valuable knowledge and the clinical expertise on the topic. The session was very insightful and helped to reveal and unreveal many aspects on the topic. So again, on behalf of Team CIPLA in person, I'm thankful to all the faculties and the Mumbai Hematology Group for arranging this session. So thank you all.
Thank you, Shrikant. And I'm grateful to CIPLA for supporting our academic activities and also giving us liposomal amphotericin as and when we required, even at reduced rate. Thank you so much for that.
Welcome, sir. Yeah. Thank you.
Everybody have a wonderful Sunday at home. Bye.
Thank you.
Thank you.